Good morning. We'd like to keep moving the meeting forward. So I'm honored to be introducing Dr. Deb Tucci, who is the director of the National Institute on Deafness and Other Communication Disorders. Dr. Tucci began her career as a clinical audiologist before earning a medical degree and completing her otolaryngology residency, all at the University of Virginia. She then completed a fellowship in neurotology at Michigan, later earning an MBA from Duke. Prior to joining the NIDCD, she was on the faculty at Duke, where she co-founded the Duke Hearing Center and directed Duke's cochlear implant program. Receiving continuous NIH funding since beginning her academic career, some of her early work continues on the theme of our other keynote speakers, with her exploration of the deprivation effects on central auditory system function. She served on the American Academy of Otolaryngology Head and Neck Surgery Research Advisory Board, as well as being the past president of the Association of Research in Otolaryngology, the American Otologic Society, and the American Neurotology Society. Not surprisingly, Dr. Tucci has received a number of prestigious awards, highlighting that she was presented with the American Otologic Society's top honor, the Award of Merit, last year in 2023. Dr. Tucci, thank you. Arguably, no one else has a better perspective and purview for your talk entitled Cochlear Implants and the Future of Hearing Healthcare.
Oh, I know. All right. Good morning, everyone. Thank you so much for the invitation to speak with you for a few minutes. I see what people are talking about with those lights. Wow. So I can't see any of you. So it's really a privilege to have the opportunity to speak with you for a few minutes and to kick off this final day of this really wonderful conference. So at NIH, there are a few military people, and one of the things that I've learned from them is that you need to give the bottom line up front, or the bluff. So that's my new term. And so I am going to tell you 4 things that I will talk to you about in the next couple of minutes. One is that there is a worldwide disparity in the uptake and access to cochlear implantation. 2, there are many opportunities for innovation in cochlear implant design and service delivery. For cochlear implantation to be fully integrated into hearing healthcare, we must address cost. It doesn't mean we have to focus solely on cost, but we need to recognize that that's a concern of many in the healthcare system. And 4th, we need better data and data standardization so that we can better demonstrate the outcomes, the value of cochlear implantation, and the cost effectiveness of this intervention. So I think we all have the same goal in making cochlear implantation a reality for more people worldwide. So I have no financial disclosures. So this is the scope of the problem. So the recently released Global Burden for Disease data from 2021 shows now that there are 1.5 billion people, or 20% of the world's population, with some degree of hearing loss. The vast majority of those have mild to moderate hearing loss. And this pie chart here shows the number of people in millions who have moderately severe, profound, or complete hearing loss. So these would traditionally be potential candidates for cochlear implantation. So there are a little under 200 million people worldwide who either could be candidates for cochlear implantation or sometime in their life trajectory were candidates for cochlear implantation, for example, at the time of their birth. So the reasons we think for low uptake of cochlear implants, I missed the main point of this, is that of all of these people, only 1 million people, we think, have been implanted with cochlear implants to date. So this represents only about 1% of all people worldwide who are candidates. And this isn't just a problem in lower income countries, but we know that the same disparities exist, for example, in the United States and Europe. So reasons for low uptake are lack of integration into hearing healthcare in most countries, including high-income countries, professional and capacity limitations throughout the continuum of care, cost, and even more importantly, a lack of understanding of the benefit relative to cost across the lifetime. There are many opportunities for innovation, and I've heard a lot about access to care over the course of the last couple of days of this conference. So there are many opportunities throughout the continuum of care to innovate, to provide services more expeditiously, less expensively. But I think it all starts with candidacy determination. And the fact is that hearing care is not integrated into hearing health care, at least not in the United States and not in many countries. So I think one of the keys to integrating hearing health care and cochlear implant care into the healthcare system is to advocate for hearing screening in primary care clinics. I think there are ways to do this. The U.S. Preventative Services Task Force has not endorsed this as evidence-based, but has laid out a path that we can follow to integrate more successfully. Cochlear implant surgery and activation and programming are areas that are bottlenecks in many countries. This included, I think, there aren't enough cochlear implant surgeons, certainly not enough audiologists. So we need to consider how to innovate to bring care to patients. We've talked a lot about telemedicine, teleaudiology, telehealth in general, and this is one of the possible solutions, but I think we have to remember that internet connectivity and availability is not good in many areas, including in many high-income countries and in rural areas, for example. And when it does exist, there may be limitations in the ability of people to use the technology. So it's not a panacea, although it is a start. There are many opportunities for innovation in cochlear implant design. This is a figure from Fangang Zhang's paper celebrating the millionth cochlear implant a couple of years ago, showing that there was incremental progress in development of effective speech processing strategies through the early 1900s with the introduction of the CIS speech processing strategy. So cochlear implants are extremely successful in providing for good speech discrimination and quiet, but we know that there are still challenges in difficult listening situations. So one of the potential innovations that I hope will come to fruition in the next several years is the utilization of new algorithms using AI and machine learning. In particular, AI has the ability to deal with nonlinearities in speech that are more difficult to handle with traditional engineering algorithms. So I'm looking for significant progress in this area, and this is certainly something that's of interest to NIDCD to support. There's been a lot of talk about improving the electrode neural interface, and all of these programs have been supported by NIDCD, and I look for further progress in the years ahead. First, to develop more flexible, smaller diameter, less traumatic electrode arrays. Second, to investigate further how to increase the number of effective information channels. Optogenetic stimulation holds great promise. As you can see in the figures on the right, optical stimulation can be more targeted than electrical stimulation without the current spread and the channel interactions, but potentially could be combined with the advantages of electrical stimulation. There have been programs to develop other sites of stimulation that could have some advantages. For example, auditory nerve stimulation that has access to a broader frequency range, including stimulation of low-frequency fibers at lower thresholds and with reduced channel interactions. We've talked about drug-eluting electrodes, in this case, potentially use of nerve growth factors to improve neural survival. Yesterday, we heard a lot about surgical advances, including robotic insertion techniques, other atraumatic insertions, and ECOG monitoring. Programs that have worked to improve electrode placement have been supported by NIH, including magnetic steering with robotic systems to optimize placement. We heard yesterday about DEX electrodes that can decrease the inflammatory response to the electrode, and Zwitter ionic coating that can do the same and decrease the fibrosis. Recently, a Korean team published a paper on manufacturable electrode arrays. I think this holds great promise both for innovation in electrode design and also potentially could decrease costs by introducing machine-made electrodes. We're in the era of precision medicine, and cochlear implantation is no exception. We know that we can improve performance by personalizing, for example, the selection of a cochlear implant electrode based on preoperative measures. It's possible to optimize mapping if we can identify survival areas that have good survival of peripheral neural processes, for example, and program specifically to those areas. I think that there's great potential to utilize approaches that optimize the role of the hearing brain in cochlear implant rehabilitation. And some of those opportunities include potential pharmacological adjunct therapy to reopen the critical period for auditory learning, and the use of imaging techniques to identify the development of cross-modal plasticity and help to inform the timing of cochlear implantation and progress of auditory stimulation. We already have a menu of options that we can customize to hearing loss and needs, but this needs to be communicated better, again, to the rest of the healthcare team, what options we have for treatment of individuals with different types of hearing loss. And there's potentially the option even for further expansion of indications if you consider that there are a large number of individuals with presbycusis with very severe high-frequency losses that can't benefit from traditional amplification, and potentially this is a new population that could benefit from cochlear implantation. So there is a tension between customization and standardization and cost, and I think we have to work through these issues, but certainly using more personalized approaches to improve performance is something that is of great interest. There are opportunities to decrease cost. I don't think that we need to worry about cost primarily when looking to innovate, because new technologies are always expensive. But what should happen is that we have new technologies, and then over time, the market forces bring down the cost of these technologies. We see this time and time again. So keeping in mind that costs are a major driver of lack of accessibility, I think is extremely important. And one of the factors that could be most effective in decreasing costs is to have manufactured electrode arrays. I talk about data standardization almost every day. I think that this is critically important to understand our outcomes and to communicate those outcomes effectively to large portions of the healthcare system. There is an effort between many of you in the cochlear implant community and the FDA to define minimum reporting standards, and I urge everyone here to strongly support these efforts. They are critically important to be able to generate large data sets with consistent reporting measures across data sets and be able to better understand outcomes and enhance our ability to demonstrate benefit relative to cost. So we know that cochlear implantation is cost effective in all but the poorest countries, but I think that point is lost on many people in the healthcare system. Everything that I talked about is represented in NIDCD's strategic plan. Themes 1 and 2 have to do with basic science, the basic underpinnings of auditory function and cochlear implantation. Themes 3 and 4 have to do with precision medicine and care delivery. So we need to establish best practices, and then we need to disseminate those and implement them in the specific healthcare setting in which the patients are. So we're going to operate differently in rural America than we will in inner city Chicago or Vancouver. And theme 5 has to do with data science. Again, this is critically important to move us forward. And theme 6 is technology. So here we have the focus on AI, machine learning, and other technologies that can improve performance. So how can we change the landscape of hearing healthcare and integrate cochlear implantation more fully into the healthcare system? First is to consider ways such as hearing screening in primary care clinics that can help make primary care providers more aware of hearing loss as a serious condition and one that can be treated. Recognize and identify the challenges and barriers to optimization of cochlear implant technology and accessibility. Prioritize cost reduction, but not at the expense of developing new innovative technology solutions. And last, data are critically important and must be standardized so that we have a common language that can increase the knowledge base and help demonstrate the value of cochlear implantation and the cost-benefit ratio, which is very favorable. So that's all I have. Thank you so much, and enjoy the rest of the conference.